Okay, we're going to continue Chapter 44, Part 2, Glomerular Disease and Miscellaneous Disorders. First, let's look at nephrotic syndrome. It's characterized by proteinuria, hypoalbuminemia, hyperlipidemia, edema, and massive urinary protein loss. This picture shows the sequence of events in nephrotic syndrome. Glomerular membrane, normally impermeable to large proteins, becomes permeable to proteins, especially albumin. Albumin lost in urine, which is the hyperalbuminuria. Immunoglobulins are lost, which causes altered immunity. The liver is stressed and cannot keep up with the demand for albumin because the kidney is flushing it all out, so hypoalbuminemia occurs. Fluid shifts from the plasma to the interstitial spaces. When the fluid shifts, it causes hypovolemia, which stimulates the renin-angiotensin system, resulting in the secretion of ADH and aldosterone. Then hypercoagulability occurs because of changes in the child's coag factors. The stressed liver starts increasing synthesis of lipoprotein, which causes hyperlipidemia. Primary disease, also known as idiopathic nephrosis, childhood nephrosis, or minimal change nephrotic syndrome. 85% of children have primary. 95% of these children respond to steroid therapy. Usually occurs in children 2 to 7 years of age. Involves remissions or exacerbations. Primary affects only the kidneys, like the glomerulonephritis. The cause of the minimal change nephrotic syndrome is unknown, and how it increases the glomerular permeability is unknown. What happens, though, is that the glomerular membrane allows large protein molecules to pass through and end up in the urine. Immunoglobulins are lost, which causes altered immunity. The liver is stressed and cannot keep up with the demand for albumin because the kidney is flushing it all out. So hypoalbuminemia occurs. Then hypercoagulability occurs because of the changes in the child's coag factors, which we stated this earlier. The stressed liver starts increasing synthesis of lipoprotein, which causes what? Yes, as previously announced, hyperlipidemia. Secondary nephrotic syndrome results from systemic disease, drugs, or toxins that affect kidney function. It is associated with glomerular changes or damage. Congenital nephrotic syndrome. It is an autosomal recessive disorder. Okay, so let's talk about some symptoms and treatment. Symptoms: generalized edema, weight gain, hypertension, irritability, lethargy, anorexia, pallor, frothy appearing urine, massive proteinuria, decreased serum protein, and elevated serum lipids. Diagnosis is based on history, symptoms, and lab work. Urinalysis, serum albumin, sodium, BUN, cholesterol, electrolytes are completed. Renal ultrasound might be done to rule out structural problems. Treatment focuses on decreasing proteinuria, relieving edema, managing associated symptoms, improving nutrition, and infection prevention. Steroids like prednisone will decrease proteinuria within 3 weeks. Give albumin and diuretics to reduce edema. ACE inhibitors will decrease the protein excretion. Immunosuppressants and immunomodulators may be used to prolong remissions for children with frequent relapses. It's important to monitor electrolyte levels because with diuretics, children can develop hypovolemia and it can alter their electrolyte levels. For children with massive edema who don't respond to fluid restrictions, albumin and Lasix may be given. Okay, monitor for side effects. Protect children from infections. Prevent skin breakdowns. Diet, they need normal protein, low salt. No added salt either during the corticosteroid treatment. Total body sodium will be normal unless edema is severe. Provide emotional support. For discharge teaching, weigh the child daily, look at the medication side effects, signs and symptoms of a relapse, and infection prevention. Monitor for side effects of steroids and make sure they are tapered off, not just abruptly ended. If the child is getting albumin, monitor for fluid volume overload. Monitor for hypovolemic shock. So why are these children at risk for developing infection? Because they are on steroids, and those suppress the immune system. So teach the parents to avoid crowded places such as Walmart, Target, Kmart, shopping malls, church, etc., and avoid exposure to people who are known to be ill. Avoid those recently vaccinated with live viruses and keep up on the vaccine schedules. Teach good hand hygiene. Okay, let's talk about acute glomerular nephritis. It may be the primary event or manifestation of another disorder. Acute occurs after infection with group A beta hemolytic streptococcus. Latent period of 10 to 21 days. Affects boys more than girls, about 2 to 1. Peaks between the ages of 6 to 7 years of age. Clinical manifestations are oliguria, edema, hypertension, circulatory congestion, hematuria. Bleeding in the upper urinary tract causes urine to appear smoky. Microscopic hematuria usually also presents. Gross hematuria in about 50% of cases. Proteinuria. An increased amount of protein reflects the increased severity of the renal disease. So pathophysiology. This latent period occurs between the strep infection and onset of symptoms. The most common type of inflammation of the glomeruli of the kidneys can also be caused by staph, pneumococcus, and Coxsackie virus. Acute hypertension may cause encephalopathy, headache, nausea, vomiting, lethargy, seizures. So what happens is that the child comes down with strep throat or infection of the upper respiratory tract or skin, recovers, and then 10 to 21 days later develops signs of this. Glomerular damage occurs from antigen antibody complexes that clog up the glomeruli, leading to inflammation and obstruction. Capillaries in the glomeruli are obstructed, so glomerular filtration rate is decreased. Vascular permeability increases, allowing the red blood cells to be excreted. Sodium and water are retained, expanding the intravascular and interstitial compartments, which results in what? You got it, edema. Okay, so let's look at some diagnosis and treatment. So diagnostics: serum BUN, creatinine elevated, serum protein decreased, white blood cells elevated, ASO levels vary. If the ASO level is elevated, then that means there are antibodies from a recent strep throat infection. But if the infection was from the skin, then the ASO level probably won't elevate. So we're going to do a UA. We're going to see hematuria, proteinuria, red blood cells, and white blood cells. For treatment, it's centered around supportive care. Edema and hypertension are treated with sodium restriction and diuretics. Antibiotics may be given to treat the infection if it hasn't cleared. So what's the big difference in these two? Which one causes massive edema? Nephrotic syndrome. Which one occurs after an infection? Acute glomerulonephritis. So we also want to monitor eyes and nose, vital signs, weigh daily, bed rest, prevent skin breakdown. Monitor their diet, no added salt, low protein diet. Monitor for hypertension, seizures, CHF, renal failure, and pulmonary effusion. Good prognosis is that most recover without significant renal impairment. It may appear that the child is anemic, but it's likely that it's due to dilution from the extracellular volume. Okay, now let's talk about hemolytic uremic syndrome, also referred to as HUS, acute renal disease that results in acute and chronic renal failure. However, it is an uncommon illness. It affects children less than 5 years of age. They have a triad of symptoms: hemolytic anemia, thrombocytopenia, and acute renal failure. So what happens is that the children become ill with presumably a GI illness like vomiting, diarrhea, UTI, URI, and then appear to recover. Then 1 to 2 weeks later, they develop HUS. Presenting symptoms are irritability, fever, abdominal pain, vomiting, diarrhea, mild jaundice, edema, or ascites. The CNS can also be affected in 20% of cases. The initial infection is a specific strain of E. coli. The E. coli produces a toxin that damages the glomeruli, collecting ducts, distal tubules, lining of the glomerular arterioles. This leads to acute renal failure. Children need dialysis and sometimes even a kidney transplant. This can absolutely be fatal. Also associated with Rickettsia organisms, certain viruses, E. coli, pneumococci, Shigella, Salmonella. The source of the infection can be from food, juices, swimming pools, drinking water, and etc. So, prognosis. Recovery rate of 95%, and then residual renal impairment for about 10 to 50%. Long-term complications include chronic renal failure, hypertension, and CNS disorders. Let's talk about nephroblastoma, also known as WILMS tumor. It's a malignant encapsulated intrarenal tumor that occurs in preschool children, 3 times more common in African American children. Peak age of diagnosis is 3 years. It's more frequent in males. It's rapidly growing, doubles in size in about 11 to 13 days. These are sometimes associated with other congenital anomalies such as absent eye irises, hemihypertrophy, that's an abnormal growth of half the body, genital urinary anomalies, nevi, and hamartomas, which are benign nodule-like growths. Then we have the Beckwith-Wiedemann syndrome. This suggests that there is a genetic link to this particular tumor. They are a firm lobulated mass, usually on one side of the abdomen, and often discovered by a parent when they are bathing the child. There may be some hypertension associated with this since the tumor is located within the kidney. They may have some pain and hematuria as well. Look at box 44-5 on page 1408 of your textbook. These are diagnosed by the imaging studies. Okay, so let's look at the WILMS tumor management. Nursing alert. Never, 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 never palpate. Treatment is surgery. Remove the affected kidney and look for metastasis. Chemotherapy with or without radiation therapy could be potential. Prognosis with surgery is good. 90% of chance of cure if it's in the early stages. 70% of metastatic cases have long-term survival. Surgeons must be extremely careful when removing the tumor because you don't want it to break and release all those cancer cells in the abdomen. For that reason, parents must be very careful when handling the child as well. Do not palpate it as a nurse. If a mass is felt, notify the MD and place the child on bed rest until it is evaluated. Surgery is scheduled ASAP, within 24 to 48 hours of admission. Chemo or radiation may be done pre-op to reduce tumor size. Radiation and chemo may follow after surgery as well. Chemo and radiation can induce secondary cancers, so that's a risk factor. WILMS tumor can also recur, especially in the lungs. We're going to briefly discuss renal failure, acute versus chronic. Renal failure should be a review from your med-surg. Acute occurs over days, weeks. It's usually reversible. Chronic occurs slowly and causes permanent damage. We have azotemia. That's an accumulation of nitrogen in the blood. Uremia is the other word associated with renal failure. It's more advanced azotemia. Basically, it occurs when the accumulation of nitrogen produces toxic symptoms. Azotemia is not life-threatening, but uremia is. So, chronic renal failure affects on growth and development. Growth often delayed, puberty often delayed, uremic environment affects hormones. Children end up on a growth hormone injection, such as erythropoietin injections. Anemia is treated with injections of erythropoietin. Bone deformities may be corrected with braces, surgery, or therapy. Teeth are often discolored. They may have alterations in size and shape. Often they are hypomineralized, and they may have lots of canker sores. Diet becomes very important. Water is not usually limited, it is encouraged. Low protein diet can be implemented as well as a low potassium or low sodium and chloride. Recall, if calcium is low, phosphorus is high. So high phosphorus is controlled by oral administration of calcium carbonate or other phosphate binding agents that decrease the GI absorption of phosphorus, thus reducing the serum phosphorus. Children receive vitamin D supplements to aid in the absorption of calcium and suppress parathyroid levels. Metabolic acidosis is corrected with sodium bicarb or sodium and potassium citrate. Hypertension is managed by low sodium diet, fluid restriction, diuretics. Seizures are managed with anti-seizure meds. Infections are treated swiftly. When the child reaches end-stage renal disease, the next step is kidney transplantation or dialysis. The problem with renal transplant in children, they may need transplantation 2 or 3 times in their life. Look at study sheet for renal failure. Let's look at some psychosocial challenges. Children with renal failure are at a particular risk of psychosocial challenges. Altered body image. They'll have a short stature, delayed onset of puberty, possible side effects of medication. They may feel being different from their peers, such as they may have a presence of a catheter, they may have the special diet, and etc. That can give them reasons to feel different. Restrictions on physical activity may particularly affect adolescents. They may feel depressed or hostile. This is really common in children. Challenges with schooling. Don't forget, these children also have lowered immunity. They're going to be at a higher risk of getting infections. They may miss school often, especially if they're on hemodialysis. Uremia decreases cognition and affects the ability for them to concentrate. So here's some strategies for success. Encourage promotion in age-appropriate activities. Remember, to teach the parents attendance at school is important. They may need alternative schooling arrangements. Promote the child's self-worth and self-esteem. For adolescents, slowly move them towards greater self-care. This concludes Chapter 44.